अब यहाँ पे ना आवाज कहाँ खुल गया?
उस दिन जैसा नहीं होना चाहिए। इसको भी म्यूट कर दे, इसको भी म्यूट कर दे।
बंद कर
ये आवाज कहाँ से आ-
म्यूट है, ठीक है। इसको म्यूट कर दीजिए। है। आपका जब आप इसको ऑन
Good afternoon, sir. We'll just do a sound check. Could you just switch on your unmute yourself? We'll just do a sound check.
सब कुछ हेलो करो।
इको हो रहा है ना?
ये इसको बंद कर दो।
Sir, could you please help us out? Are there two devices that are connected from where you are online? Are there two devices, mobile and laptop? Maybe could you check that, please?
कोई आसपास में कोई ज्वाइन किया है क्या अटेंडी?
हेलो
Yeah, sir.
डॉक्टर नम्रता
We'll just. Yes, sir. Now it is perfect. There was an echo that was coming. Now it is gone.
भी साउंड नहीं आ रहा है।
आएगी सर।
अभी ठीक है ना sound? हाँ. Now it is perfect, sir. Thank you.
नम्रता इस टेक्नोलॉजीज आर मेकिंग मी सो अनकंफर्टेबल। को बुला लो ना भाई।
नो सब लोग हाँ फिर से सब लोग फिर सीखा रही हैं सर सब
We are
लोग
all evolving.
नहीं नहीं नहीं
सर
नहीं।
सब लोग पीछे बैठेंगे इधर क्योंकि
कोई
कैमरा आपका ये यूज होगा ना सर।
कोई बात नहीं, कोई बात
हम लोग यहाँ बैठ जाएंगे चलिए।
A very warm good afternoon, everyone. Before we formally begin our webinar, I request you all to kindly register on this link that has been displayed on your screen right now. Alternatively, you could also scan the QR code that is being displayed. The link is also posted in the chat box. Please go to the link. There will be a brief questionnaire, and I request you all to kindly take that questionnaire. We'll just wait for a few more minutes for more participants to join us. So please bear with us. In the meantime, kindly do go to this link that has been posted in your chat box and also the QR code that is being displayed on your screen right now. Thank you.
Manya, we can start the session, please, officially.
Yes, sir. Yes, sir. We can start. Namrata, please go ahead.
Welcome, everyone. Thank you for joining us for today's webinar. My name is Dr. Namrata Mohan, and I serve as the project officer with the Empathy Campaign, an initiative of the Institute of Liver and Biliary Sciences and the Airports Authority of India. The Institute of Liver and Biliary Sciences is a deemed to be university established by the government of NCT of Delhi. It is an international center of excellence dedicated to the field of specialized healthcare and research in liver and disorders, including viral hepatitis. Albius, through the Empathy Campaign, has been spearheading the integrated initiative for the prevention and control of viral hepatitis in India, with an aim to enhance community awareness on hepatitis and lay stress on preventive measures among medical practitioners as well as the general population, especially the high-risk groups in the hotspots. And in this, the series of organizing virtual webinars are part of the call to action initiatives under the campaign. In continuum of the same, I extend my warm welcome to the host of the day, the National Academy of Medical Sciences, India, to the national webinar on recent advances in the prevention and control of hepatitis B and C. Once again, I welcome you all, the distinguished panelists, respected speakers, and the audience from the fraternity. A very warm good afternoon to you all. An honorary mention to Professor Shiv Kumar Sareen, the vision behind the initiative, the force that drives us all, and the leader, true to the way that we understand a leader, one who knows the way, goes the way, and shows the way. Without further ado, may I now please welcome Dr. Umesh Kapil, Officiating Secretary, National Academy of Medical Sciences, for delivering the welcome address. Sir, please.
Good afternoon to all of you. I extend my warm welcome to all the members of National Academy of Medical Sciences, all the fellows of National Academy of Medical Sciences, and special my welcome to Dr. Churamani ji. She has joined from Varanasi. We are most grateful to you, ma'am, for joining us. And also we have some of the participants from Bangladesh, also from Sri Lanka, and they have joined us. We are to participate in the webinar. The main aim we know about HBV and HCV are important public health problem in our country. And if you look at the communicable diseases, so we have malaria, we have HIV, we have tuberculosis, and hepatitis is coming as another big way. And if you look at the overall prevalence and the magnitude of HBV and HCV, it's large. And although we are unable to provide that priority to these hepatitis per se, now we intend to undertake these webinars with a public health perspective. We learned so many things from these webinars, honestly speaking. And some of the questions we don't have the answers. And then we try to look into it and then share it with our people, participants. Now, I can share 2-3 simple examples. Like one of the participants asked us, whether a person can be infected with 2 HCV variants simultaneously. This is something very interesting. Then we had questions. Very common question is the gap between dose 1 and dose 2. We don't have any answer. No, we do have answer. Sorry, we do have answer. First dose is first dose, second dose is second dose. Then we do have questions like breastfeeding during the HCV infection, breastfeeding during HBV chronic infection. Does these chronic infections, if a mother become pregnant, does she delivers a child with abnormalities? What should be the diet given? It should be high protein diet, low protein diet, high fat diet. So these are many questions which are being asked, and we learn from and we try to answer some of all the experts. They would like to take up these issues and they would like to respond. My most sincere thanks to Dr. Ajit and Dr. Archana, we have been requesting and making them work extra for our webinars. Thank you, Dr. Archana, Dr. Ajit. And last but not the least, I would like to thank our Vice Chancellor and Senior Professor of Hepatology, Professor Shiv Kumar Sareen, who has kindly agreed to deliver a keynote address. And I must say that sir is a living legend, honestly. Okay, living legend. There are very few people whom you know that who have been able to undertake so much of work, so much of contribution, not only nationally, internationally. And wherever we go, and when we just say that we come from Dr. Shiv Sareen, we're working with Shiv Sareen, with the amount of respect and regard which we get is tremendous. So with these few words, I thank again to all of you, and we are trying to disseminate the important public health issues related to HBV and HCV. And if there are any specific questions on the clinical side, please do ask Dr. Sareen. Like we had a question from Durg, Madhya Pradesh, asking that what is the impact of COVID vaccine, COVID disease on liver diseases. So these are some of the important questions, and we try to answer them. And during the question answer session, we'll take care of it. Thank you very much. Over to you, Namrata ji.
Thank you so much, sir, for elucidating the need for opening such platforms to encourage the discussions on the challenge of viral hepatitis. And now, please allow me to welcome the vision behind the entire team of ILBS and the edifying force of the empathy campaign. Dr. Shiv Kumar Sareen, Honorable Vice Chancellor, Institute of Liver and Biliary Sciences, the leader who translated the vision of ILBS into reality, transforming it to reach the pinnacle it is at today. Sir is a Padma Bhushan awardee, a befitting jewel in the fabric of health fraternity, and the president of the National Academy of Medical Sciences. Sir, I invite you to kindly please deliver a keynote address.
Thank you, and thanks, Dr. Kapil, Namrata, Manya. This webinar is no conflict of interest. I do hold the position of President NAMS, but we have done this webinar from the side of the ILBS. So please forgive us if there is any misconception. We are just requesting everyone to join. Like the 5 fingers, this is hepatitis A. This is hepatitis B, this is C, this is D, this is E. 5 types of viruses. If you have A or E, A like the choti ungli hai, this is in children. E is in adult. They are both by food and water. The B, C and D, they are by blood or blood products. All these cause chronic diseases. means they do not go away from blood for more than 6 months. The attempt to make you become our ambassador and make you as part of the program to disseminate, I would like you to remember these 3 important fingers. Hepatitis B causes cirrhosis and liver cancer. So does hepatitis C. Hepatitis D always comes with B. So finally, we are left with B and C. Hepatitis B comes from mother 99% of the time. So you find somebody who is hepatitis B positive, suddenly you say, the person is very worried, अरे मुझे hepatitis B हो गया, बड़ी tension हो जाती. But suppose he is 30-year-old. How old is the virus? 30 years, because he got it from his mother, but never came to know that it is present in his body. These are stealthy viruses. Chupchap pade rehte hain. And then after a while they activate and then cause the disease. So our aim is to find out how much damage the virus has caused in 30 years in that person. If there is no severe damage which occurs in 90%, no worries. You can treat. Hepatitis C comes from blood and blood transfusion. So somebody has got a blood before 2001, when the blood banks were not screening for hepatitis C. किसी की सर्जरी हुई, gynae, heart, angiography, prostate, uterine. अगर किसी को 2001 से पहले any time you have got blood or surgery, you have a risk of hepatitis C. Otherwise, it is less because now blood is safe. Both these viruses are specific for liver cells, which over a period of time die and are replaced by hard fibrous tissue called fibrosis, which can progress to cirrhosis. In hepatitis C, if it persists for 36 months, 30% will have fibrosis, and maybe 10% can have cirrhosis and cancers. Hepatitis B, if it persists, 10% will have fibrosis and about 1% will have cancers. In India, there are about 40 million people with B and C, maybe more. Our attempt is a drop in the ocean. The National Viral Hepatitis Control Program by the government permits free diagnosis, free treatment and monitoring to both B and C. But people never come out. They are scared. If they tell in the society that I have hepatitis B, the wife will not talk, the husband may leave. You do not get a job in a medical fraternity. Nurse है तो उसे job नहीं मिलेगा. Doctor से कहेंगे तुम surgery नहीं कर सकते. Wife छोड़ जाती है, husband छोड़ जाता है wife को. So because of this social stigma, social non-acceptance, there is a fear not to get tested. I went to Jammu, Kashmir about 15 years ago. In one small village, there were 1,300 people living, of which about 900 were positive. तो जो सड़क थी पहाड़ी वाली जहां से नीचे गिर जाओ, वो साइड पे हेपेटाइटिस सी वालों को चल सकते थे, दूसरे वाले पहाड़ी की साइड, सेफ साइड, उनका छाता भी छू जाता तो उसको निकाल देते. But this is by blood, not by touching of your umbrella. But the society was so fearful, afraid that they would not talk to each other. Our job now as a doctor is to give everybody that confidence that these are preventable and treatable diseases. Safe blood, no hepatitis C, and hepatitis B drugs are available. For hepatitis C, a 3-month course can cure, not even TB can be cured in about 90 to 95%. You can finish like a nail cutter, you cut the nail, hepatitis C can be cured. And hepatitis B can be suppressed like HIV for lifelong and may not cause more problem. So we have 3 strategies. If you vaccinate every newborn today for hepatitis B, there will be no hepatitis B. Vaccine is almost 99% effective. So future generation is protected. And you vaccinate everybody else, so transmission is protected, prevented. And treat everybody, treat all. So there is nobody who has the virus like HIV cannot be transmitted if you give drug, hepatitis B cannot be transmitted. These are the strategies. And hepatitis C, you can easily treat everybody by giving drugs and eradicate the virus. So, third strategy is empathy. Empathy is a program which is empowering people against hepatitis. You are not sympathizing. You do not have mercy kind of a, I am good, he is bad. No, it is empathy. It is my feeling that the other person is suffering for no mistake of his. Can you choose your mother? No. You are born. If mother has hepatitis B, you will get hepatitis B. What can you do? So we have empathy for such people. You are going for a journey, you get roadside accident, you need blood, you get a blood and you get virus. What is your mistake? Nothing. You get hepatitis C for not knowing that you are getting a blood from a person who has hepatitis C. So we should have empathy. So these series of webinars, which Professor Kapil has very kindly spearheaded, and the team, is an attempt for our medical people to be part of it. And I am very grateful NAMS has allowed us this platform. And through each of those experts who are attending or may share our knowledge with others and tell us what all we can do for making these viruses slowly disseminate. If you keep a target of like WHO 2030, hepatitis C can be eliminated. There are just about 7 million. Encourage everyone to get tested and eradicate. And hepatitis B, vaccinate and treat. With these few words, I would like one more time to thank NAMS for allowing us, and I compliment Professor Kapil for making this happen. And I see my very close friends, Archana and Ajit. Both are exceptionally talented for these kinds of epidemiological work, and Manya. And thank you all for this. And I'm also seeing Ekta, who is the nodal person for our WHO Collaborative Center on viral hepatitis. Thank you, Kapil.
Thank you so much, sir. It is always a privilege to listen to you, the way you bring out the challenges of those living with hepatitis B and C. It is really telling to understand what they live with day in and day out. Thank you so much for being here with us today. The session now begins, and we will turn the time over for the first presenter today, Dr. Manya Prasad, who is the Assistant Professor, Clinical Research Epidemiology at the Institute of Liver and Biliary Sciences, New Delhi. She is well published with over 35 international and national articles in Medline Index journals. Her area of interest are epidemiology, medical research, systematic reviews, and meta-analysis, and evidence-based medicine. She has facilitated many workshops on research methodology, evidence-based medicine, and GRADE tool. She also holds the gold medal in her MD final exam and also is the proud recipient of the International Epidemiology Association Fellowship. I welcome you, ma'am, and over to you.
Thank you. Thank you so much, Namrata, for that kind introduction. And I extend my gratitude to National Academy of Medical Sciences for jointly organizing this webinar with ILBS, and also thank you to all the attendees that have joined in today to talk about this very important issue. So without much ado, I will begin with the presentation. And what I've been asked to talk about is the current disease burden of hepatitis B and C in India. What I will go through is the reported estimates of the prevalence of chronic infection in India of hepatitis B and C. I will also do a critical review of the current literature, so this will be a little bit of an academic discussion, and provide the estimates from recent studies. We'll also discuss the rate of liver complications of cirrhosis in HCC with hepatitis B and C, and finish with some sepsis. So why do we need to think about this and turn our attention to hepatitis now? Well, because it's one of the leading causes of mortality worldwide, and it's certainly a very important public health problem in Southeast Asia, of which India is a part. Hepatitis saw about 1.4 million deaths in 2015, which is comparable to TB and HIV. But in contrast to TB and HIV, this is a communicable disease where mortality was observed to be increasing. And it's responsible for at least as many, if not more, deaths annually than TB, AIDS, or malaria. 90% of these deaths are due to hepatitis B and C infections. We also particularly need to think about this seriously because this is a disease that's amenable to very efficient prevention and control. So there's a very, very effective vaccine for hepatitis B, and there's a cure for hepatitis C, and we have very good drugs to manage hepatitis B infection. So this is something that we need to turn our attention to. In terms of how the elimination efforts for hepatitis have been impacted by the pandemic, well, COVID-19 poses a major challenge in achieving hepatitis elimination. And it is documented that hepatitis suffered among the highest disruption of all diseases, which is more than that for HIV, malaria, and tuberculosis. And so, of course, essential interventions, important strategies such as vaccinations, training, and health education have suffered a huge deal because of COVID-19, and it's about time we think about this again. When we talk about the burden of hepatitis B and C, what we're worried about, of course, is the very serious complications of cirrhosis and hepatocellular carcinoma. And in terms of the burden of mortality due to this disease, these two complications hold a very high attributable risk for mortality in hepatitis B and C, and I will give the estimates later on. So if we talk about the worldwide prevalence of hepatitis B and C, 296 million people worldwide are living with chronic hepatitis B and 68 million with chronic hepatitis C. According to the WHO estimate in 2015, hepatitis counted for around 1.4 million deaths worldwide. And in the 2019 estimate, what was reported is that 820,000 deaths were due to hepatitis B, and these were mostly due to cirrhosis and hepatocellular carcinoma, very serious complications for hepatitis B and C. So up to 40% of chronic HBV virus develop serious sequelae during their lifetime. And HBV and HCV infections with cirrhosis accounted for 720,000 of these deaths, and HCC for around 500,000 deaths. So huge numbers there in terms of the burden. So this is how the burden of cases is spread out across the WHO regions, 296 million in total. And there are some regions that are affected more severely. So Western Pacific and African regions, they're a huge burden. But also Southeast Asia, which witnesses 60 million cases currently of hepatitis B. Coming on to hepatitis C, again, there's disparity across the WHO regions in terms of number of cases. Overall, 68 million. And again, Western Pacific and some other regions hold a greater burden. Southeast Asia region, 10 million cases, of which India is a part, of course. Within the Euro region, we see that some countries are more severely affected than others. So Bangladesh, Myanmar, Indonesia, Thailand, etc. And the way that they have measured the burden is by measuring the prevalence of surface Can you hear me?
Yes, we can hear you now. Sorry for the technical glitch.
Okay. I'm going to go back. Can you see my screen?
Yes, it's visible.
Okay. So sorry about that. There are three major research groups.
I believe there is a network problem and we are facing some connectivity issues. Kindly bear with us.
Namrata, can you hear me now?
We can hear you now.
Okay. And you can see my screen again, right?
Yes.
I think there's a problem with the connection. Sorry about that. So the first estimate arises from Schweitzer et al., which is a paper that was published in the Lancet in
I apologize for the technical drop that is happening in the internet connectivity. Ma'am, we can see your frame moving now. I believe the bars, when they turn red, is when the connectivity gets lost. You are connected again, ma'am. Please go ahead.
Okay. Let's hope that that was the last time that the connection got a little haywire. But so there are and the prevalence reported by Schweitzer et al., that's 1.46%, is purported to be a reliable estimate. So the point estimates are mentioned here at the top, and what we see here is the confidence interval. And so there is a significant overlap in the confidence interval from the three research groups. WHO estimate is 1.95%, and they have engaged a number of agencies to arrive at this summary estimate. And then the third group is the CDA Polaris group, which reported a slightly higher prevalence of 2.5%, but then there is some overlap with the WHO estimate there. So just a word about what these three research groups did. They've all done a systematic review and meta-analysis of published literature, of peer-reviewed literature. And the WHO also had some unpublished data that they obtained from their member states. And these are the databases that they have searched, pretty much a large overlap in terms of where they looked for the published studies. But there is some differences with regard to the countries that they have covered. So little bit of variation in what they covered in terms of the population and the countries, which could possibly the reason for that slight variation in the summary estimate. Almost all three of them excluded high-risk populations and non-representative populations from arriving at that summary estimate. So this paper that is purported to be a reliable estimate is the Schweitzer et al. Paper, and they have reviewed literature from 1965 to 2014, which included 129 studies and 3.7 million subjects. The prevalence that they've reported, as I mentioned, is 1.46%, which accounts for about 17 million chronic HBV carriers. If we look at how the prevalence has changed across two time periods, from the 1950s to 1980s, and compare that to a decade later, we can see that there is a reduction in the prevalence. So the prevalence of hepatitis C is seen to be reducing in India, and this can possibly be attributed to the vaccination. This is also reflected in the WHO data, and we can see here that compared to the pre-vaccination era, there is a reduction in the prevalence as observed in all ages as well as under 5. And we can possibly attribute this to the expansion of the vaccination program. So if we come on to the recent studies that have reported burden of hepatitis B, which is what I have depicted in the next 3 slides, we will see here that there is some discrepancy in the reported estimates, and what could possibly account for that is that there really isn't a very robust nationally representative survey that has reported the prevalence of hepatitis B in India. We have a number of studies that have been conducted in variable populations. So some included general populations, other eye donors, cataract patients, healthcare workers, etc. They also differ slightly in their testing method. So Eliza and some, and other methods in others. And they're mostly subnational studies rather than a representative national one. So this could account for the variability in the reported estimates, which have a wide range. Coming on to hepatitis C, this is again a systematic review that was published that estimated 0.09 to 15% was the estimate from all the studies included in this review. And if we take the estimate only from community-based studies on general population, blood donors, and pregnant women, the estimate is 0.85%, which is 6 to 12 million chronic HCV infected in India. And 3 to 9 million of these are active HCV infections, and chronic HCV infection accounts for up to 30% of HCC and 20% of cirrhosis. So again, an important cause for both of these liver complications. So as you can tell with what I just reviewed, the quality of reporting is highly variable with regard to the current literature that reports estimates of burden of chronic hepatitis B and C in India. There's a combination of robust as well as non-representative studies. They've been done in different age groups, different time points, different populations, so very high variability there. And we don't have strata-specific estimates with regard to age and gender. Also, very few studies in young children and infants. A lot of the studies were done in blood donors, which would lead to a healthy donor effect. And since healthier people are likely to come in for donation, it may be an underestimate that they are reporting. And most of the studies are subnational, and some have targeted very high endemicity areas like tribal areas. If we look at the mortality from hepatitis B, what this graph depicts is the proportion of deaths in hepatitis B and C that are due to HCC and cirrhosis. So the darkly shaded portion is due to cirrhosis, and the lightly shaded one is due to hepatocellular carcinoma, and the very, very darkly shaded portion is acute hepatitis. And so what you can tell is that the large proportion of the mortality that's happening is due to these liver complications, both of these very important liver complications. And that's true for both chronic HBV and HCV. In terms of numbers, also this suggests the same thing. So absolute estimated deaths due to liver cirrhosis, 141,000. So huge burden there. and the 8th standardized death rate 7.8 per 100,000. So again, high mortality due to liver cirrhosis. This was a paper that was derived from the Global Burden of Disease study. And of course, one very important caveat before I talk about this data is that it relies on certification of death, which is very, very poor for India. But what they have reported is the 8th standardized incidence rate for liver complications due to HBV. So this is both liver cirrhosis and HCC together. And they've compared the estimate from 2007 to 2017. If we look at just the point estimate, we will see that globally there is a percentage change that's negative. So there's a reduction, 2.55% reduction. And for India, that point estimate does not point to a reduction. So that's a 7% increase. But then this data is not reliable. One, because there's poor documentation of death, but also because the confidence interval is quite wide. And so there's uncertainty with regard to this. But there is an indication that there is a worrying trend with regard to mortality due to liver complications. And this is also so this is incidence and this is death rate. And so this trend is also there for the death rate due to cirrhosis in HCC, with the point estimate pointing towards a 2% increase in comparison in 2017, but then not a very reliable estimate because of a very wide confidence interval. And then this trend holds true for both cancer and cirrhosis individually as well. What this points towards is that we need a public health response, and more speakers in subsequent sessions will talk about this strategy. But what the WHO Global Health Sector Strategy aims at is elimination in terms of reduction in death by 65% by 2030, and reduction in new cases by 90% by 2030. The only way that this is possible is by a public health approach. We need a multi-pronged strategy, and we need engagement of a lot of different stakeholders, and we need a lot of broad-based strategies that are advocated in the National Viral Hepatitis Control Program, which Ekta ma'am will talk about. So I will finish here, and thank you very much for your attention. In the interest of time, I'll quickly switch back to Namrata. Namrata, over to you.
Thank you so much, Dr. Manya. Although numbers haven't been my strongest feat, but your presentation definitely underscored the need for the urgent response to address the challenge of viral hepatitis, which is emerging as a silent killer in epidemic proportions. Thank you once again. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the question box, which you may kindly locate in Zoom control panel. Our team will try to address them during the presentation, and we will also have time to take up the questions towards the end during the plenary session. Please allow me to now welcome the next speaker, Dr. Ajit Singh Badoriya, Associate Professor, Community and Family Medicine, AIIMS Rishikesh. So did his graduation from GRMC Gwalior and also did his specialization in community medicine from NSC BMC Jabalpur. He has 5 years of experience at the Apex Liver Institute of Country, ILBS, New Delhi, and is as an epidemiologist and project coordinator to the WHO CC on viral hepatitis. His area of research lies in viral hepatitis and is very well published with more than 100 scientific papers, including publications in the Lancet and the Lancet Gastrohepatology. I extend my very warm welcome to you, sir. Over to you.
Thank you so much, Dr. Namrata, for introducing me. A very good afternoon to all of you. And here I would like to just take the opportunity to mention that for most of my achievements, which are mentioned by Dr. Namrata, which are there in the slides, the credit goes to Institute of Liver and Biliary Sciences, ILBS, to those 5 years of working over there, learning from ILBS, from all my team members, and under the able guidance of Professor Shiv Kumar Sareen sir. I'm also thankful to Umesh Kapil sir, who is a mentor to me from the beginning of my career, and for also providing me this opportunity to contribute in this very useful series of webinar, which are targeting spreading awareness, disseminating knowledge to one and all. And I'm sure that this spreading awareness, making people understand hepatitis B and hepatitis C will play a major role towards elimination targets at large. So today I'll be talking about transmission, and we all know that transmission of a communicable disease is something which is very important to understand, so that we can plan prevention of transmission. Similarly, as we are doing for COVID-19, we all know, we understand how it transmits. We all know, and now we all understand how we can at least try to stop the transmission of the disease. So similarly, we'll talk about the transmission, the modes of transmission of hepatitis B and hepatitis C in this session. And we'll also try to understand how we can strategize to minimize these transmission or to prevent these transmissions by general precautions, by vaccination as a best strategy for hepatitis B, post-exposure prophylaxis as the best strategy among those who are regularly exposed to such infections. So as it was very nicely explained by Professor Sareen sir, that we have 5 viruses. Smaller one is A, last one is E. A among children is more common. E among adults is more common, is also fatal in pregnancy. Then we have 3B, C, and D, which are transmitted by either blood or through blood products. So these are the common understanding about hepatitis, 5 types of hepatitis viruses, how they transmit. We'll talk in more detail about the transmission of hepatitis B and hepatitis C mainly. Why? Because Dr. Manya, she has explained that most of the burden of the diseases as a chronic infection is due to hepatitis B and hepatitis C. 96% of the mortality is attributable to hepatitis B and hepatitis C. May you call it cirrhosis, may you call it liver cancer. So that's why we are mainly focusing on hepatitis B and C. D, we all know, is a defective virus. It goes along with B as a co-infection occurring together, or as a super infection occurring after, when there is already existing B infection in the person. So if we talk about parental transmission, the most common is blood-borne, which occurs through multiple blood transfusions. So we know that we are providing safe blood, they are tested, but still the chances of being blood tested in a window period, or sometimes missing that infection during those testing approaches or techniques, we transmit hepatitis B and hepatitis C along with HIV and other infections to the patient. Other nosocomial routes, they are also important mode of transmission, like dialysis, unsafe injection practices in healthcare setting, needle stick injuries among healthcare workers, surgeries, dental procedures, organ transplantation may also transmit these infections. Sharing of needles among person who inject drug. This is something which we should think of, because these are the high risk group, and we know that there are people who inject drugs, and during that practices, they most of the times share needles. So this sharing of needle also leads to transmission of hepatitis B and C. Then sexual transmission is common as HIV. Perinatal transmission, mother to child transmission, which is also known as vertical transmission. And this transmission is the most common mode of transmission for hepatitis B. So we know that these are the different modes of transmission. Out of that, vertical transmission, mother to child, is most common for hepatitis B. Transmission through unsafe blood and unsafe injection is the most common mode of transmission for hepatitis C. Just to remember as which are the most common, how if you're targeting somewhere in some region, what should be the strategy? If you're targeting specifically B, what should be the strategy for targeting specifically C? Then also inapparent horizontal transmissions are also seen, which occurs among the close household contacts, children playing together, sharing toothbrush, adults sharing razors, or sometimes there is exposure to infected blood during these close contacts. So this is known as horizontal transmission, and this can also lead to transmission of hepatitis B and C. So this slides tell you about different modes of transmission. And second information is that mother to child transmission is the most common for hepatitis B. Unsafe blood and unsafe injection is the most common mode of transmission for hepatitis C. So why this mother to child transmission is common in India? Why it is common in developing countries? So there are multiple reasons, there are multiple factors which contribute to such transmission. So these are listed in this slide: high birth rates, low institutional deliveries, poor antenatal care, poor birth hygiene, poor coverage of hepatitis B birth dose. We'll talk more about this birth dose intervention, and low testing for hepatitis B during ANC care. So these are the factors which leads to transmission of hepatitis B from mother to child. So what can be done? How we can block, how we can prevent this mother to child transmission? The strategy includes testing of all pregnant female for hepatitis B. All newborns should get a birth dose within 24 hours. All newborns with a mother infected to hepatitis B should get a dose of hepatitis B immunoglobulin within 48 hours. So we can have these strategies in place in our healthcare and delivery system. We are sure that we can prevent hepatitis B in future. We can eliminate hepatitis B in future. So this slide is also important. I hope most of you must be knowing also about this relationship between hepatitis B infection and age at acquisition with the conversion into chronicity. So you can see in this on y-axis, it's percentage of infection with outcomes like with going into chronic infection or a symptomatic infection, and then age on x-axis. So as if the transmission is occurring early, if it is a mother to child transmission, then 90% of these transmissions, they can convert into a chronic infection. That means our target, as explained by Dr. Manya, is to eliminate hepatitis by 2030. We have to reduce incidence by 90%. We have to reduce mortality by 65%. So if we want to reduce transmission in incidence, we have to reduce transmission. We don't want that a mother transmit the infection to the newborn. So checking for mother to child transmission can help this point. Second is, if we can check the infection at birth, then we can reduce that infection to convert into chronicity also. So no chronic infection, no cirrhosis, no liver cancer, no increase in mortality, and there we can see a drop in mortality. So with age, the chances of converting hepatitis B infection into a chronic infection decreases, and the chances of a hepatitis B infection converting into an acute infection, a symptomatic infection, increases, which has a lower mortality, which has a lower consequences as compared to chronic infection. So this graphs gives us a better understanding about how and what should be done to prevent hepatitis B transmission. So this slide tells about vaccination as a key strategy to prevent hepatitis B infection. So we know that hepatitis B infection is already there in universal immunization program. And so if we can give timely birth dose, if we can give 3 doses of vaccination as is planned in the universal immunization coverage, we can prevent mother to child transmission also, and we can prevent this child in getting hepatitis B infection in future also. So childhood vaccination is an important strategy, along with vaccination of healthcare workers, vaccination of high risk group people. And this in the green box, you can see that antibody titer for hepatitis B surface antigen is a very important marker to see whether you are protected for hepatitis B after vaccination complete sequence or not. So if it is more than 10, that means you can be assured that now you are protected for hepatitis B transmission. Other than vaccination, other strategies which can help us in preventing transmission of hepatitis B is mainly similar to I'll say the mode of approach of preventing transmission in HIV, that is screening of blood and blood products, giving safe blood, safe injections, taking care of those who are involved in occupation and exposed to hepatitis B infections, so occupational safety, harm reduction interventions like providing safe, sterile needle and syringes free to people who inject drugs, so that they should be kept away from sharing needles. So this is reducing the harm in that particular specific group. And safe sex can also help in preventing some of the transmission of infections. So this slides makes you understand about what should be the preventive strategies for hepatitis B infection transmission. So if hepatitis B vaccination is the most important strategy, what is the current status? So current status for hepatitis B 3-dose vaccination coverage is more than 80%. So that's good for us. Our target is to achieve this coverage as 90%. So this is something which is doable. So it is around 87%, and we want to increase it to 90%. So this is in the universal immunization program since 2007-2008, more than 20 years. So that's why the coverages are good, and we hope that we can utilize this strategy to prevent hepatitis B transmission and to eliminate hepatitis B in future. So why vaccination? Why vaccine is an important strategy? So in this graph, you can see that there are two x-axis. One on this side, this is vaccine coverage. On other side, these are chronic infections. And on x-axis, it's the year of birth. So year of birth from 1990 to 2014, as we see this blue line and orange line, blue, the coverage of hepatitis B vaccine third dose, orange, the coverage of hepatitis B birth dose. As they both increases, you can see the decline in this black line, which tells us about the number of chronic infections. So chronic infections from 1990 dropped from 50 lakh to 5 lakh when we increase the coverage of vaccine from 0 to 90%. So as we increase the coverage, there will be a drop in hepatitis B transmission, and in hepatitis B new infection, in hepatitis B burden. So vaccine is a very important strategy for hepatitis B. So again, showing the same graph because I want to emphasize more on birth dose. So a timely birth dose means when we give a birth dose within 24 hours of birth. If we are doing so, we can prevent mother-to-child transmission. We can prevent early infection occurring at birth. We can prevent this infection converting 90% of the times into chronic infection. We can prevent cirrhosis. We can prevent liver cancer. We can prevent mortality occurring due to hepatitis B chronic infection. So what is the current status of the coverage of birth dose? There are multiple challenges for giving this birth dose because institutional deliveries are not that common, because maybe A&M and they feel hesitant, even the family members, they feel hesitant or not confident enough in giving a newborn baby an intramuscular injection. So birth dose coverage is very poor. It is around 38% globally, and the target is to increase it to 90%. So maybe like in future, if we can emphasize on how to increase this coverage of birth dose, how we can increase institutional deliveries, how we can ensure that every newborn should get a birth dose of hepatitis B vaccine, we can prevent mother-to-child transmission to a significant level. That was all about hepatitis B transmission and prevention. We know that hepatitis C is mainly transmitted by unsafe blood and unsafe injections. So how we can prevent it? We can prevent it by giving safe blood, safe injections, harm reduction interventions by preventing people who inject drugs sharing needles, by providing them free needles and free syringes, safe sex, and occupational safety. So these are the strategies for hepatitis C, which are very much similar to HIV. We do not have a vaccine yet. There was a question in previous webinars about why we do not have a vaccine, because this virus is very diverse. We have multiple genotypes, multiple variants. So scientists, they are finding it difficult to make a vaccine for hepatitis C. Maybe in future we can have a vaccine, and then we can have a good strategy to prevent hepatitis C transmission also. This one in red, test and treat, is a very strong strategy, not only for preventing mortality, but also for preventing new infection. How? Now we have hepatitis C, the drugs against hepatitis C, which can cure hepatitis C in a shorter period of 3 months. So these are simple, oral, safe drugs, which are now freely available through the program. So if we can give these drugs to a person who is tested hepatitis C positive, we can 100% cure hepatitis C infection. So curing a person who was asymptomatic, who was in the community spreading infection, can act as a good preventive strategy to block the transmission also. So test and treat strategy for hepatitis C is a promising strategy to prevent transmission of hepatitis C infection in the community. So what should we do if there is a exposure to hepatitis B virus during healthcare setting or during any high risk activity where a person is exposed to hepatitis B virus? So if the person is unvaccinated, give hepatitis B immunoglobulin stat and then initiate hepatitis B vaccine series 016. If the person is previously vaccinated and we do not know about antibody titer, if we know about antibody titer, it was sometimes in the life more than 10, no need to give any treatment. If we do not know, we can get it done. If it's more than 10, no need to give any treatment. If it is less than 10 and was never more than 10 in the past life of that person, then give a hepatitis B immunoglobulin stat and give 1 dose of vaccine booster. So these are the strategies for preventing post-exposure transmission of infection. This slide is very much related to public health strategy target, which was mentioned very clearly by Global Health Sector Strategy on Viral Hepatitis in 2016 document. So this tells about that we want to reduce incidence to 90%. We want to reduce mortality to 65% by 2030. So if we want to reduce, if we want to have an impact on hepatitis B incidence and hepatitis C incidence to be reduced to less than 90% what they are today, the important approach is prevention of transmission. If we can prevent transmission of these two diseases, we can prevent new cases. So to get this impact, what should be done? We should have these 5 strategies in place. So first is 3-dose hepatitis B vaccine. Coverage is very good, 87%. We have to just increase it to 90%. Very much doable. To prevent mother-to-child transmission, now we have to focus on birth dose. Current coverage is only 30%. We have to increase it to 90%. A lot need to be done for this particular strategy. Safe blood, we are giving to 85%. We have to give it to 100% recipient. Unsafe injections, currently they are 5.2%. We have to reduce it to 0%. There should be no unsafe injection which is a potential, which has a potential hazard of transmitting any infection. So unsafe injections to 0%. Harm reduction, as we have talked in the previous slides, giving injection sets, giving sterile needles and syringes to people who inject drug. So per person per year, currently we are giving around 29 through the system, through different programs or through NGO. We want to increase it to 300 per person per year so that we can be assured that they are not sharing needles and now they cannot transmit hepatitis C or hepatitis B infections. So this is what we have planned to do so that we can achieve this 90% drop in the incidence of hepatitis B and hepatitis C. So just to summarize, hepatitis B and C with D, they are parentally transmitted. Hepatitis B infection, if occurring in infancy through mother-to-child transmission or early childhood through any blood transfusion or any injection, they are at very high risk of converting into chronic infection. Vaccination is the most effective, most promising strategy to prevent hepatitis B transmission and also as a good strategy to eliminate it also in future. Birth dose, if given with 2 additional doses of hepatitis B vaccine, can prevent more than 90% of mother-to-child transmission. And if the antibody titer is more than 10, then it indicates adequate protection against hepatitis B transmission. Other than this, safe blood, safe injection, and safe sex practices, they are effective tool to prevent both hepatitis B and hepatitis C along with HIV. And I like to add test and treat policy for hepatitis B and C can also be a very promising strategy to prevent transmission. Why? Because most of the, I'll say more than 90% of hepatitis B, hepatitis C infected people, they are asymptomatic. They're living in the community, transmitting infection. So we can find out the way to find out these missing millions by testing and then treating them so that they can be stopped. They can be at least, they'll not transmit infection in the community. Can be a very promising strategy to prevent transmission of hepatitis B and hepatitis C and to achieve our elimination goals. So that's all from my side, and we can have questions in panel discussion session. Over to you, Namrata.
Thank you so much, Dr. Ajit. A very informative session yet again, and very well elucidated how wide can a birth dose be in averting the progression of the disease chain and bringing out an effective change in the outcomes. Thank you so much once again. And we do understand you have prior commitments, so perhaps we'll be missing you in the panel discussion. There is a question that I'd like to direct to you right now. Vaccinating against hepatitis B for immunocompromised subjects like chronic kidney disease is tricky and may not achieve protective levels. What is your strategy for such patients?
So we'll know about vaccination in detail in the next session. Still, just to answer this question at this point of time. So we know that people, when they are immunocompromised, then we do not get sufficient level of antibody titers which are protective, so that we can be assured that now they are protective. So in such case of immunocompromised patients, dose is doubled, and then we give double dose, and we complete the whole series. Then we go for antibody titer. If it is still low, we can go for a booster. We can again recheck antibody titer. So maybe I think that could be the only approach, so that we can be assured about making them also safe against getting that infection. Giving the vaccine series and then checking, and then giving booster, then again checking the antibody titers, so that we can be assured that now they have achieved those levels.
Thank you so much for clearing that query out. Thank you so much. We will now go ahead and take the next presentation. Just a kind reminder, please be sure to type your questions into the question box in your control panel. Our panelists and the speakers would attempt to answer the questions while the presentations are going on, and we will have some time towards the end of our sessions. Inviting on next, Dr. Archana Ramalingam. She is the Scientist E at the ICMR NIE Chennai. Ma'am did her graduation from JIPMER Puducherry and also went on to do her specialization in community medicine from the same institution of repute. She is a recipient of the Professor R.K. Kar Best Postgraduate as a gold medalist in the Community Medicine Award in 2014. She has worked in multiple research projects at JIPMER Puducherry and Maulana Azad Medical College, New Delhi, and also at the ILBS. She has been a resource person for several workshops on research methodology and basic epidemiology, a proud recipient of the IAPSM Ford Foundation Epidemiology Grant, and has been awarded for the best oral papers in several conferences, including IPHA and Jericon. Her area of interest include the non-communicable diseases, viral hepatitis, community-based interventions, health promotions, and medical education. Over to you, ma'am, and a very warm welcome.
Thank you so much, Dr. Namrata, for that kind introduction. And before I share my screen, I also would like to thank Professor Umesh Kapil as well as Professor Shiv Sareen for giving me this opportunity to share my views with you. And a warm welcome to all the participants from the National Academy of Medical Sciences. So without taking much of your time, let me go straight ahead into my presentation. Is my screen visible and am I audible?
Yes, ma'am, we can see the screen and also can hear you. Please go ahead. Thank you.
So good afternoon, everyone. And I'm going to be speaking to you a little bit about screening, vaccination, and health education. I'm sure the previous speakers have already covered most of what I wanted to talk with you, but still just to revise, today I would be discussing with you on screening, vaccination, and health education. In screening, we would be mainly covering whom to screen and what are the rapid tests available for screening of B and C. And in vaccination, we'd be broadly touching upon what are the types of hepatitis B vaccines that are available, the schedule for vaccination, what to do if missed doses are there. What is, from the public health point of view, we are going to look at the coverage as well as the strategies to improve hepatitis B birth dose. And towards the end, we will be discussing a little bit about health education. So firstly, to begin with, screening for hepatitis B and C. Now, why really should we focus on hepatitis B and C screening? If you look at the cascade of care for viral hepatitis, you can see that really the bottleneck or the gap exists in testing and linkage to care. So focus should be there on testing in order to improve all the other aspects in the cascade of viral hepatitis care. Now, if you look at the global health sector strategy, which both Dr. Manya and Dr. Ajit explained, this global health sector strategy clearly lays down what are the key interventions that are required if we are to achieve the target of eliminating viral hepatitis B and C by the year 2030. Now, these broad strategies include hepatitis B vaccination, focusing on both the childhood as well as the birth dose given to infants. The other strategies are safe blood, safe injections, harm reduction, and key strategies are hepatitis B and C testing in terms of diagnosis and providing linkage to care for treatment. So the first focus of our talk is going to be about diagnostic testing. So the global health sector strategy says that in order to achieve elimination by 2030, we must be able to diagnose at least 30% of patients with chronic hepatitis B and C by the year 2020, and increase this coverage of diagnosis to 90% by the year 2030. Just to see where we stand in the Southeast Asian region, according to the recent WHO Southeast Asian regional report, we see that we have only diagnosed 10.5% of the hepatitis B virus infected chronic patients and only 6.9% of hepatitis C virus chronically infected patients. So we are far from the target for 2020, which is 30%, and very, very far from the target for 2030. So really, screening is very vital and a key strategy that we must focus on. Now, whom should we screen for viral hepatitis B and C? You just listened to Dr. Ajit and he discussed with you about the transmission dynamics. You must have understood that the key people who are at high risk for B and C are, let's say, pregnant women, etc. So whom are the screening services available within the national program? Within the national program, screening services are available for anyone who requests them by coming to the testing sites. However, we need to give high preference for individuals with high risk. Who are these key high risk groups? Pregnant women, people who use injection drugs, healthcare professionals like you and me, nurses, other frontline workers, people who are on hemodialysis, people living with HIV and who are at high risk for HIV. Of course, there are some other groups like close household contacts of B and C patients, people who get themselves tattooed in unsterile parlors, etc., who may also be at high risk for hepatitis B and C. Priority testing services need to be offered to them, but testing services under the program need to be really given to anyone who walks in and requests for testing. What are the rapid diagnostic tests that we have? Now, a lot of progress has been happening in the diagnostic field, and I'm sure Dr. Ekta will be discussing that next with you. But very, very easy, simple to use, single-use disposable diagnostic lateral immunoflow assays are available for diagnosing hepatitis B and C, even at the most peripheral level. These are very simple to use, can be read visually. You can see the control line and the test line, and you can get a simple reactive or a non-reactive result within a span of 15 to 30 minutes. So even a peripheral health worker who's stationed at the primary health center or maybe even at a health and wellness center can perform these tests and can detect or screen for hepatitis B and C and then send them to a higher facility for confirmation of diagnosis and then linkage to care. Now for B virus, we generally look for the hepatitis B surface antigen, and for C virus, we look at antibodies for hepatitis C virus in these rapid diagnostic test kits. Now, how good are these tests? These tests are really good. Their sensitivity and specificity is very high according to a recent paper, and therefore can be used definitely at the most peripheral levels for getting a good yield, and therefore we are able to diagnose more number of individuals. Now, what are some of the recent advances in strategies which the WHO is planning for screening of hepatitis B and C virus? Now, all of us know that the rapid diagnostic tests are available in India, even in the most peripheral of health services. However, still we are lagging behind in screening and diagnosis of hepatitis B and C. WHO has recently released recommendations and guidance for whether self-testing for hepatitis C virus is possible. Now, WHO has clearly said that this should be an additional approach. It should not replace the already existing approach of rapid diagnostic testing at facility level, but this can be piloted as an additional approach for hepatitis C testing. But one of the key challenges that is anticipated if you do self-testing is whether these patients will go and get themselves confirmed, and how do we ensure linkage of care. Now, this is a key area which WHO document highlights about and talks that if at all a country is planning to introduce self-testing for hepatitis C virus, then first and foremost, it must put in place within its health system facilities for people to go and get their diagnosis confirmed and also be linked to treatment and further care and follow-up. So to summarize, diagnosis is one of the key bottlenecks in the hepatitis care cascade, and screening is a key strategy. We do have very good, simple, easy to use tests which offer quick results and are highly sensitive and specific. They are very cheap as well. They can be used at health facilities, even in the most peripheral levels. Now, what the international agencies are looking at for future in order to further increase the diagnosis rate is looking at self-testing and how self-testing can be linked to care, whether there are some digital technologies that can be used or not. These are still further in the pilot phase and in the guidance phase. And that is what I wanted to discuss with you as far as screening is concerned. Moving on to hepatitis B vaccination. That is the next most important strategy. So as we discussed, there are several key interventions if we are to achieve elimination of hepatitis B and C by 2030, and hepatitis B vaccination, both childhood and birth dose, are some of the key aspects of these interventions. Just to again revise with you about hepatitis B vaccines, hepatitis B vaccine is a recombinant subunit vaccine having a viral protein, which is the hepatitis B surface antigen. Initially, when these vaccines were manufactured, these proteins were obtained from the plasma of persons with chronic hepatitis B infection. However, nowadays we have moved on to the recombinant technology. What are the common types of hepatitis B vaccine? Commonly, broadly, there are two types of vaccine. One is the monovalent vaccine, which offers only protection against the hepatitis B virus. And then we have combination vaccines, which offers protection against multiple diseases. If you look at India, for adult vaccination, generally we prefer a single antigen vaccine, which is the monovalent vaccine, the common brand available. Several brands are available. When we look at children, the government supply pentavalent vaccine is the one that is most commonly used. This, in addition to hepatitis B virus, also offers protection against diphtheria, tetanus, pertussis, and Haemophilus influenzae B. If we look at the private sector, the most commonly given vaccine for the childhood immunization is what we call as the hexavalent vaccine, which in addition to all the diseases that I mentioned for pentavalent, also offers protection against polio. It has got the IPV component as well. So these are some of the common types of vaccines available in India. If you look at the schedule of vaccination, for infants and newborn, we recommend a birth dose, which often we give only a monovalent vaccine, that is the hepatitis B vaccine, preferably as soon as possible after birth, but within the first 24 hours of birth. Followed by the primary vaccine dose series, which has got 3 doses scheduled at 6, 10, and 14 weeks. For this, the Universal Immunization Program of India uses the pentavalent combination. Recommend is usually 0.5 ml. When we look at adult vaccination, the schedule, usually we prefer a monovalent vaccine, which contains only hepatitis B surface antigen. And the schedule that we recommend is, if a person gets the first dose today, he must follow it up with the second dose after 1 month, and then the third dose after 6 months. So for adults, usually the dose that we recommend is 1 ml. Now, just to answer the question that was asked in the Q&A to Dr. Ajit, for immunocompromised individuals, though I have not mentioned in the slide, the dosage is slightly higher. So we give 2 ml of monovalent vaccine to the immunocompromised individuals. And as he rightly said, following vaccination, when we test for titers, if protective titers are not achieved, then you can repeat and give a booster dose. For some of these people who do not get adequate protection after single booster, sometimes we may have to repeat the entire series as well. So what is exactly the protection offered by hepatitis B vaccination? Following a single dose, the protection is not that great, only 16 to 40%. But following second dose and third dose, the protection is very high. So if a person has got 3 doses of hepatitis B vaccination, really the protective efficacy is about 98 to 100% as per studies. Now, what to do if a child has missed the hepatitis B vaccine dose? Now, birth dose preferably should be given as close to birth as possible, but can be given according to the program up to 24 hours. Whereas the primary doses for which the program offers the pentavalent vaccine, these can be given up to 1 year of age. But care should be taken that the spacing between 2 doses should be a minimum of 4 weeks for achieving the correct amount of antibody response. Now, for adults, wherein we give the monovalent vaccine, which has got protection only against hepatitis B, if the person takes the first dose and has forgotten to take the second dose, that is, the span has been more than 1 month, then he can take the second dose as soon as possible. But for third dose, for the monovalent vaccine, the interval between second and third should be minimum 8 weeks. Now, what about individuals who come with unreliable vaccination history? That is, they do not remember how many doses they have taken. Now, as a healthcare provider, if you're not sure whether the person has taken second dose or third dose, and if you're wondering if you can give an additional dose, then you can go ahead and give, because the CDC says that in cases where hepatitis B vaccination history is not reliable, administering extra doses of single antigen hepatitis B vaccine is really not harmful. So if your patient is not sure whether he has got 2 or 3 doses, and if you're contemplating whether you can give an additional dose, please go ahead and give the additional dose. Now, what about administering these vaccines in pregnancy? Both pregnancy and lactation are not contraindications for the vaccine. So you can safely administer this in pregnancy and lactation. And priority or preference should be given to pregnant women who are at high risk. These are the women who have got more than one sexual partner or are getting treated or evaluated for an STD, or may be currently using injection drugs, or may have a partner who is hepatitis B surface antigen positive. So if you find any of these pregnant women in your practice, then if they are not previously vaccinated, please go ahead and vaccinate them with hepatitis B vaccines. Now, how do we know whether following vaccination, adequate antibody response has been obtained or not? Now, this can be tested by testing your antibodies to hepatitis B surface antigen, which is called as anti-HBs titer test. So if the value comes more than 10 international units, that indicates adequate protective level antibody, and that means that the vaccine response is very good. So if an immunocompetent adult, a person whose immunity is good, an immunocompetent adult, once in a lifetime has got this test, titer value of more than 10, then he or she, according to studies, is protected like more than for 30 years. And of course, there is another cell-mediated immunity which will also develop. So CDC says that any individual who's an immunocompetent individual who's got an anti-HBs titer of more than 10 at least once in their lifetime, they need not really worry about booster doses. They remain protected for most of their lifetime. Now, booster doses really need to be considered in healthcare workers who are repeatedly at risk and who have not achieved this antibody response in spite of getting the primary vaccines scheduled. Now, what are the adverse events? Are these vaccines, what is the safety profile of these hepatitis B vaccines? Hepatitis B vaccines are really very, very safe. Most of the adverse events are mild, as described in this slide. You can see that if you vaccinate about 100 individuals, or if you give 100 doses of vaccines, some 3 to 5 people might complain about pain at the vaccination site. There may be mild amount of swelling or redness, and there can be slight elevation in temperature and headache. Whereas for the severe anaphylactic reaction is seen in very rare incidents, like 1.1 per million doses. If you administer, then you can hardly get one individual who get anaphylaxis, which is really the only contraindication for hepatitis B vaccines. So again, coming to our global health sector strategy, having covered the basics of hepatitis B vaccination, how have we fared as far as coverage is concerned? So we focus both on childhood and birth dose vaccination. When we look at the global health sector strategy, as Dr. Ajit has elaborated to you, in order to achieve elimination by the year 2030, we need to have the 3 primary dose vaccine series coverage at least 90% by the year 2030, and birth dose coverage 90% again by 2030. So what is the coverage of childhood vaccination in India? As per the latest NFHS, we are doing really well. The NFHS 4 showed that we were somewhere about 65%, whereas NFHS 5, which is the most recent nationwide survey, has shown that we have reached a coverage of approximately about 84%. We are doing really well, and we need to give the final push and do catch-up vaccination of people who are not vaccinated so that we can achieve a 90% vaccination of all eligible children. Why is birth dose important? Childhood dose, we are childhood primary series, we are doing really well in India. But as far as birth dose, I'm sure this slide you have seen in Dr. Ajit's presentation. Just to reiterate to you, this is a very important slide which talks to you about what is the chances of getting chronic infection if an individual gets infected early in his life. An individual who gets infected at birth, if you can see the y-axis, the chronic infection, the dotted blue line shows that the chances of having chronic infection is close to 90% in a person who has got infected at birth. Whereas if you scroll across and see individuals who are getting infected at older age group or adulthood, their chances of getting chronic infection is really very low. So the take home from this slide is early infection leads to a greater risk of chronic infection, and therefore we need to prevent early infection, specifically mother-to-child transmission of infections. And therefore, what are the strategies we have to prevent mother-to-child? The most important strategy that we have is giving a timely birth dose, which is giving hepatitis B vaccination within the first 24 hours. So when we look at the global picture, we can still see many of the African countries. This orange color represents that they do have hepatitis B in their childhood vaccination schedule, but they do not have universal birth dose of hepatitis B vaccination. Whereas in India, if you see, we have got both the childhood vaccination as well as the birth dose vaccination introduced. But how are we faring? According to the recent CRO report of the WHO, the entire CRO region coverage is slightly better than the global average, which Dr. Ajit showed you. CRO region has got a coverage of about 54%, and India, as per the same report, has got a coverage of about 56% as per the estimates from the WHO. So, are there any recent strategies that the WHO, if you ask me, is the WHO considering for birth dose coverage? One of the reasons what the WHO and other global vaccination experts have found for low coverage of birth doses, inability to maintain the conventional cold chain in most peripheral difficult to reach areas, because they may not have an ice-line refrigerator and therefore may not maintain the traditional cold chain and may not give the birth dose. One way to get around this, what the WHO is recently contemplating is a strategy which is called as controlled temperature chain strategy. Now, this is an innovative approach wherein the WHO is planning to test heat stable vaccines and trying to allow them to be kept outside of the traditional cold chain temperatures in ambient temperature settings for up to 3 days time. Can that be tried? This is what the WHO is, this is very much in the testing phase. This is a very recent strategy, and WHO is contemplating this strategy and has laid down roadmap for testing 4 heat stable vaccines like the HPV vaccine, the oral cholera vaccine, the tetanus toxoid vaccine, as well as the hepatitis B vaccine birth dose. So this is something that the WHO and other vaccine experts are contemplating now. And if this is introduced, probably we could achieve a slightly better coverage of hepatitis B birth dose in the hard and difficult to reach areas. Now, I highly recommend you to go through these 2 documents. One is by the WHO on the control temperature change strategy, what is the roadmap, and another is a modeling study published in the Lancet, which talks about if suppose we are able to give control temperature chain and also introduce a compact pre-filled auto-disabled device in the most peripheral settings, are we going to be really cost effective and are we going to improve the hepatitis B birth dose? So these are 2 highly recommended self-reading. And to summarize, what I want to really say is hepatitis B birth dose and hepatitis B childhood vaccination are some of the key strategies if we are to achieve elimination of viral hepatitis by the year 2030. Now, we do know that the 3-dose vaccine schedule for hepatitis B offers a very good protection, close to 90%, 95%, maybe some studies even say 99%. And how do you really check if you have adequate protection? Do go for an anti-HPS titer test. And what are the key strategies for mother-to-child transmission, which is key for hepatitis B, that is birth dose vaccination. And birth dose followed by 2 additional doses have got more than 90% efficacy in preventing mother-to-child transmission of hepatitis B. Before I close, I will just talk to you a little bit about health education and then turn it over to Dr. Namrata. Now, there are several strategies through which we can spread public awareness about diseases. These could be through health education posters, conducting competitions, through brand ambassadors, through social media, which is very important these days, through campaigns, and as well as bringing key policymakers onto a single table for discussing about the importance of the disease. Now, ILBS, I must really congratulate, has done all of these activities through their empathy campaign. So they have released very good posters which talk about key information messages related to viral hepatitis, like this one is on hepatitis C treatment. They have got posters on getting tested for pregnant mothers, for birth dose vaccination. They have even got general posters made for improving awareness about viral hepatitis. They have conducted several innovative competitions. The one which I like the most is the cartoon competition which they had held, where more than 40 countries, people came, and then they have been participants, and they really brought out a lot of health education materials for viral hepatitis. They have engaged with key stakeholders at schools, namely the school principals or school teachers, through an innovative approach called as the Happy School Initiative. I was very fortunate to be part of this, through which they trained all the principals and key teachers of Delhi government schools for viral hepatitis. They have a brand ambassador for their campaign in the form of Mary Com. She constantly tweets about viral hepatitis, spreads awareness to the people who follow her. And also she's got videos done both in English and Hindi so that she can spread messages against viral hepatitis. The faculty videos at ILBS, which are available on the Empathy Campaign website, do offer very good information for the general population and even healthcare providers. They have conducted several campaigns with key partner agencies through the I Pledge events. And they have also called key parliamentarians and brought them in a conclave, made them discuss the importance of viral hepatitis, how much the patients are getting discriminated, so that the parliamentarians are aware of the importance of the disease and can come out with key policy decisions which can favor the elimination of viral hepatitis. They are very active on social media and they run several campaigns. And so I really congratulate the team at ILBS for their efforts in going forward to achieve elimination of viral hepatitis from our country as well as from the region. And that is all I have for you. Thank you very much, and over to you, Dr. Namrata.
Thank you so much, ma'am. Indeed, a very engaging and a very interactive presentation. And we really appreciate how you expanded on the empathy campaign spirit and the initiatives undertaken. You are very much at the essential force behind the momentum it has gained. Thank you once again. Kindly allow me to invite for the next presentation. But before we begin, just a gentle reminder, please be sure to type your questions into the question box, which you may be able to locate in your control panel, so that all are addressed during the plenary session. Inviting on next, Dr. Ekta Gupta, Professor of Head of Clinical Virology at the Institute of Liver and Biliary Health Sciences, New Delhi. Ma'am did her graduation from GSVM Medical College, Kanpur, and went on to do her specialization in microbiology from the King George Medical College, Lucknow. She is the proud recipient of the Best Scientist Award, a gold medalist at that, for outstanding contribution in clinical research by ICMR. She is the technical resource person for developing the National Viral Hepatitis Control Program in India. She has several extramural research grants both at the national and international level to her credit. She serves as the nodal officer for the WHO-CC at the Institute and have more than 100 scientific publications in the indexed national and international journals alike, and has authored about 11 chapters in various books. Her major research interests include hepatitis viruses, transplant viruses, and dengue virus, and we are really fortunate to have her in our team. Over to you, ma'am.
Thank you, Namrata. Can you hear me?
Yes, ma'am, you're audible.
Okay. So, very good afternoon to all of you. After all these sessions, I think my talk has been, made very, very easy. Everyone has covered. So, I'll be very quick. I'm going to share my screen. Can you see the screen as well?
Yes, ma'am, we can see the screen. Please do go ahead. Thank you.
Okay. So very good evening to all the people who are attending this webinar, and I thank the Empathy Campaign team and Professor Sareen sir for such a wonderful concept of giving awareness to the healthcare workers about the hepatitis B and C, how our progress is moving. So now you've heard what is the prevalence, what are the preventive measures, what is the role of vaccination. So I'll just very quickly tell you what is at the government level, the government of India has done so far, and what is exactly the idea behind this national. I hope all of you know that there is recently we have launched National Viral Hepatitis Control Program in India. So this is just a repetition, but an important slide to share. That as you can all see, that it is the chronic hepatitis B and C infections which brought a lot of attention globally in the year 2016 and 17, that apart from HIV, malaria, tuberculosis, these are the two problems which require a lot of attention. So the global health sector strategy, where the government of India was also a signatory to it, they declared that each government has to do work on decreasing the number of new cases. So from where the word 2030, the targets 2030 came from here, from this global health sector strategy, which was done. And all the governments were signatory to it, including our government, where they said that yes, we will all start doing some work in our country for the elimination and reducing the number of cases by these hepatitis B and C infections. So when you really need to work upon a particular disease so that it is eliminated or removed, you really need to focus, like the way we prepare a budget. So what are the areas which require our more attention? So globally, WHO worked on it, the targets, and it was felt that, as you can all see, what is the baseline and what we target. So although we are talking, a lot of work needs to be done about prevention of mother-to-child transmission, that is offering hepatitis B vaccination less than 12 hours, because within 12 hours of birth, because see, the baseline percentage is 39 and you have to reach to 90. But what actually is lacking is, look at the diagnosis. So as everybody is saying that please make these diagnoses available, make this things available, and let people know that they have to come. As you have heard from Professor Sareen also, that more and more people should come, because see, only 9% and 20% are the people whom we are actually offering diagnosis, where you have to make this target to go to 90%. So the problem is diagnosis, lack of diagnosis. So you have the strategy, you know prevention, you know how to control, but when people are not coming up, get themselves tested, and you really do not know who to offer treatment, that becomes a major lacking. So this is the sector for B. You have to increase, look at the percentage who are actually infected and whom you're actually offering diagnosis, and look at the way to whom you are offering hepatitis C diagnosis. This was beautifully shown by Sir Professor Sareen, that to remember viral hepatitis, you just need to remember 5 fingers of your hands. So in India, we know all 5 viruses are there. A and E, they are the normal sporadic viral hepatitis, so which we acquire from food and contaminated water and food, and they are already hyperendemic. So when you have a problem where you see cases occurring in large proportions throughout the year, then you call it hyperendemic, and they can occur as sporadic outbreaks also. And this problem is controlled through, there are a lot of other programs, like you have Swachh Bharat Mission, you have safe, sanitation, and all those safe water, and all those things are being happening. So A and E can be controlled. But what is problematic was B and C, because they are the one which are transmitted through blood and blood products. And we know that this is just look at the wide prevalence. So there is no cohesive or correct number which is given to us of what is the real prevalence of B and C in our country. And so that is why it really was decided that India needs a well-documented action program to combat this problem of hepatitis. What was our contribution? So you all know that ILVA started way back in 2008 and formally inaugurated in 2010. From that day onwards, we had a mission that this, at least liver diseases and viral hepatitis was one of the most important liver disease. We need to do something for the country. So we became WHO Collaborative Center, and along with Government of India, 4 consecutive technical consultative meets were done at ILBS under the guidance of Professor Singh in 2014, 15, 16, and 17, where we actually brought to the notice of the Government of India that how important is this problem of hepatitis B and C, especially B and C in our country, and something needs to be done. And we started moving towards the development of National Viral Hepatitis Control Program in the country. So finally, in the year 2018, 28th of July, that is the World Hepatitis Day, we launched this National Viral Hepatitis Control Program in the country. These are the guidelines. The PDFs are all available. The National Center for Disease Control, NCDC, through the Government of India is the key stakeholder for this program, and these are all available, these PDFs, which talks about in detail how the what are the national guidelines, lab testing guidelines, what is the operational guidelines, how the management has to be done. And fortunately, I've been a part of these since the very beginning, from 2012, as ILBS became WHO Collaborative Center. And so these guidelines are very nicely explained that what needs to be done in cases of hepatitis B and C. And another good thing in India is that most of the countries' national hepatitis control program only focuses on hepatitis C. But our country is the first, and we could convince the minister that yes, hepatitis B is also a problem and it should also be included in this program. So with the aims, what are the aims of these? So you have National TB program, malaria program, so you have this National Viral Hepatitis Control Program. So the main aim is elimination of hepatitis C by 2030. As we all know that hepatitis C infection, hepatitis C is an RNA virus, which I'll tell you, and it does not get, it's not like B and HIV that it remains lifelong in a person's body. So you can give a short course of treatment and can remove the virus from the blood and from the body. So it is very, very much treatable with the available drugs right now. So elimination of C by 2030 is a major aim. We will work on hepatitis B because B cannot be totally eradicated from the body. So you need to just suppress it so that the liver functions. So the person who's infected with B can live with a good, healthy liver for a longer time. Right now, with the management which is available, we just need to, we only suppress hepatitis B viral infection. A and E, the morbidity and mortality, because in certain less than 1% case, A can land up into, you all know, acute liver failure, and E is also associated with liver failure, acute on onset or acute insult on an underlying chronic liver disease. So that mortality portion also needs to be controlled. So our National Viral Hepatitis Control Program in India is comprehensive, including all these 4 major viruses. We have not included D because D is a piggyback virus on B. So yes, if there is a complicated B case, ultimately the B will also be taken care of. So B, C, A, and E are the main focus for this program. This is a simplistic diagram that how this program has been made to work. Is had already started working. Many states have started it. The funds have started going. The testing has started, and few states have even started giving the treatments. Now, this program in the center is controlled through the National Health Mission. So there is a National Viral Hepatitis Management Unit, which is right now at the National Center for Disease Control, NCDC. And they have got this NVHMU. There are technical resource groups who are continuously meeting, and they are the one who make these guidelines, and the meetings happen every 6 monthly, and I'm fortunate to be a part of these technical resource group at the national level. The funding, procurement of drugs and kits will all be done at the central level, and then they'll be quality tested, and then they will go to state. So each state, through their state health mission, like the National Health Mission. So in each state, you had state health mission. They will make a state nodal officer and will make a steering committee for their own state. Punjab has started, Haryana has started, Uttarakhand, Delhi state has also made their own Delhi State Viral Hepatitis Committee. And 2 or 3 meetings have already been done. I'm again fortunate to be a part of Delhi State Program Committee. And then each state will decide that where they want to make viral hepatitis state lab, how many treatment centers they want to make in their state, depending upon whether you have big tertiary hospitals or medical colleges in your state, or what is the population of your state, and how many wards and sectors you have divided the state. So you can make as many model treatment centers in your state. Now, the model treatment centers and the state lab will also have the flexibility, unlike NACO and TB programs, that they can collaborate. If they do not have all the facility, they can also outsource to a private lab, because the cost per test for DNA RNA will be fixed at the national level. So either you can do, if you have state-of-the-art instruments for RT-PCR testing, or you can have a public-private partnership, and the payment of the reimbursement of the test at the rate decided by the National Health Program can be done. Similarly, treatment centers, now then these states can make their own district, small district sites, where the small treatment center and district labs will be there. And at sub-district level, you have these primary health centers where simple diagnostics in the form of rapid diagnostic test, which Archana had shown, and simple drug dispensation units will be made at the district level. To give you more clarity, so how the diagnosis and treatment we are going to offer through this program is, we're going to screen and screen all, because as you know, the WHO guidelines clearly say that if the prevalence is more than 2 to 4% for B and 2% for C, then you have to offer general population screening. So since in India, I have showed you the prevalence rate for hepatitis B, we are 4 to 8, that is intermediate kind of prevalence, and for C almost 2%. So we are going to screen all in under this program, and yes, preference will be given to high risk group, but then you're going to offer screening to all, and the screening will be done by serological test, which are rapid guard tests, which Archana has shown. Now, when a person is serological, antibody or surface antigen positive or antibody positive, the confirmation of active infection needs to be done because treatment is targeting this active infection. So the confirmation will be done by molecular tests, which are simple PCR assays or RT-PCR, real-time PCR-based assays, which are HBV viral load or HCV viral load. And they can, then once the person is put on treatment, confirmed for an infection, he'll be put on treatment. Simple, uncomplicated case, if your liver is non-cirrhotic, the drug can be taken from the sub-district level. And for C, you just require a 12-week course of treatment. For B, it's a lifelong. So you need to keep on getting your treatment like HIV and be on a follow-up role under the program. In case you have some complication in form of co-infections or cirrhotic liver, in that case, the treatment will not be offered at the sub-district. It will be offered at the model treatment center at the state level, which just again summarizing the diagnosis by which we offer in this program. The simple sample which will be collected for B and C screening is blood. We do it on serum for serum or plasma. By rapid diagnostic card test, which are the lateral flow through assays, will test for either hepatitis B surface antigen presence or antibody to HCV presence. State level labs can also have a provision for ELISA or chemiluminescence assays, which are more specific and sensitive than rapid card test. And then they will be in case of any discordance between the test and patient's other reports. Then the molecular test, which will be simple viral load and RT-PCR, will be available at the state level lab for the confirmation of infection. So at the sub-district level, you will just have the card test available, and they will refer to the district level wherever an RT-PCR access is available, so that the ongoing active infection is tested. State level will also have ELISA and chemiluminescence more than the district level, so that any discordance in the results of RDT is there, then they are able to settle it down. Center of Excellence will have entire facility even for sequencing, because very complicated cases or wherever a drug response is not, a treatment response is not attained, in that case, the drug resistance testing or genotyping can be done. Telling about the treatment at the different levels. So the sub-district level will only be able to dispense the drugs and follow up the patients, whosoever they involve in their program. District hospitals will be able to manage the uncomplicated cases, and they should have a linkage way to send the complicated cases. Model treatment centers will be ideally where management of the complicated cases can be done. They should be having endoscopy unit, a good radiology services, so that management of all complicated cases can be done at their level. Now, what are the challenges we are anticipating? We anticipate that once you screen a patient for a serological test and sending for a confirmatory PCR test, there you will have a largest drop-off. So you really need to establish a strong linkage so that the patient is not lost and he's involved into the chain of the program. The communication of result is also a challenge, but thanks to COVID, many things, the silver lining of this COVID use and pandemic is that many things were sorted. So the labs and how the report immediately needs to be shared, everything through the HIS and electronic portal has become possible. So this we are also going to look into. Another important thing is treatment follow-up, initiation and follow-up. So especially for hepatitis B, because the treatment is given lifelong. So you really need to see that there is adherence to treatment, that the patient doesn't leave the treatment in between and lands up into being a drug-resistant case. And management of complicated cases, like if the patient really requires some radiological intervention, that endoscopy and services should be available, or in very few cases, if transplant is needed, even that services should be available in certain complicated cases. So I'll just briefly touch upon what are the guidelines under this program. Hepatitis B virus, in a simple term, is a DNA virus. So this virus causes a lifelong infection, and just like HIV goes and gets, it's a hepatotropic virus. So it targets liver hepatocytes. So goes into the hepatocytes, binds into the host chromosome, gets integrated, and then remains lifelong. Although from the peripheral blood, it may clear within 6 months to give you an acute picture, or then it can reactivate anytime. The important markers which are available are hepatitis B surface antigen, which is present on the virus surface. And it is an important marker by which you can check for infection. Although there are a lot of antibodies to it, but anti-HPS is a titer which has been told by Archana, but this is a marker for exposure to the virus, or following an acute exposure, or vaccination, and more so used when you vaccinate a person to know the immune response. So a person gets vaccinated by hepatitis B vaccine, but you check for its immune response by looking at the antibody it generates against the HBsAg by anti-HPS, and then we call that person as immune. Now, in a normal, healthy person who is not at all immunocompromised, you give hepatitis B vaccination, you might not even look for an anti-HPS response. But those who are high-risk group, like healthcare workers who are on dialysis, co-infected with HIV, HCV, in them, or transplant recipients or cancer patients, there you need to see and look for their immune response by checking at least once, only once, that your body can mount an antibody response. Now, DNA is another important test by an active ongoing infection is seen. Now, if you look at how the hepatitis B is transmitted, as everybody has said, age is an important factor. So if you acquire this infection, as Sir has said, age of the virus is what is the age of the person, because mostly infection is transmitted from mother to child. More than 95% will land up into this chronic hepatitis B. Now, that is why the role of at birth vaccination within 12 hours or 24 hours, because we have to break this chain. If you are able to achieve this, your problem of chronic hepatitis B is well sorted. Now, once a person gets hepatitis B virus and is not able, so a child gets it, not able to clear. But if an adult acquires this through an accidental exposure to the virus, in that case, only less than 5% will go into a chronic infection state, leading to affecting the liver. Otherwise, it gets cleared, and which has got all the five kind of names. So acute hepatitis B infection is when your body is able to clear from the blood hepatitis B surface antigen as well as DNA within 6 months of time, mostly asymptomatic, and that is why we say that you may not have any sign and symptom. Acute viral hepatitis in the form of jaundice, loss of appetite is seen in very few, and less than 1% might land up into an acute liver failure. Chronic hepatitis B can persist lifelong. Person will have a healthy liver, may not have any problem, but might lead to cirrhotic liver, which is controlled by the body, then compensated, and once the body loses its control, then it becomes a decompensated cirrhosis, and ultimately leading to a liver failure or some HCC. Now, in hepatitis B, what are the guidelines, national guidelines and WHO guidelines? We will screen a patient for a hepatitis B surface antigen. HBsAg is a marker of infection. Now, if the person is HBsAg positive, we just look for its liver health. How is the liver? If the liver is perfectly fine, there is no cirrhosis, then you may look for other criteria to start the treatment. We go by the age. We look for a serum liver function test, which is SGPT, that is alanine aminotransaminase, ALT test. If your HBsAg positive, your liver is healthy, but your ALT is persistently abnormal, and then you look for DNA, and your DNA is more than 4 log, that is 20,000 international units per ml, you have to start the patient on treatment and monitor. Treatment is given in the form of nucleoside analog, tenofovir, entecavir is the treatment. And monitoring, once you put the patient on treatment, then you have to do 3 monthly, call him and get a DNA done to look for the treatment response and see that the virus is under control. Means the DNA level should be negative or at least below the negligible zone and around lower limit of detection, so that the hepatitis B virus replication is controlled. So you keep on calling the patient. Now, if you're surface antigen positive and your liver, through various criteria, you can get an ultrasound done, you can get a fibroscan done, or non-invasive test like apti score, it comes out to be cirrhotic, you have to start the treatment. So 2 cases, if HbA1c is positive, liver is healthy, but ALT is abnormal and more than 20,000, start treatment. If HbA1c is positive, liver is cirrhosed, you have to start the treatment. Otherwise, in certain other conditions, you can defer the treatment, keep on calling the patient, at least annually, keep on measuring these ALT and DNA and identifying whether I have to start. Because mind it, once you put a patient on treatment with the current drugs, you need to give it lifelong and keep on monitoring. Now, under the program, these are the drug combinations and they are available at free of cost by wherever a model treatment center or a treatment center is made in the state. These drugs can be given to the patient at free of cost. And even all the testing which I had shown, that is HbA1c and HBV DNA, will be done at free of cost under the program. So this is a walkthrough of how a patient will come under the program. If it is a model treatment center, you will get an HbA1c done, you will look for the liver health, either through ultrasound or through a simple apti score, which is a Spartate to platelet ratio. Look for a fibroscan or anything by which you have to see that the liver is non-cirrhosed. And then as per the algorithm, you put the patient on treatment and make a treatment card and then keep calling the patient, giving the treatment so that the person is enrolled into the program. Hepatitis C virus is a simpler virus. It's an RNA virus and does not have many tests attached to it. So it has envelope protein and a core protein against which the antibodies are formed. And the antibody to HCV is an important marker which tells you about exposure to infection. Confirmation of an ongoing infection is done by an HCV RNA test. So this antibody to HCV is not a marker of protection. Again, it's a marker of infection. Now, if a person turns out to be antibody positive, 20 to 30% cases, only 20%, because usually you will not have symptoms, so it is an asymptomatic infection. In 20 to 30%, our body will be able to clear the RNA on its own, so that we call it as an acute HCV infection. However, the antibody will still remain in person. And in only few, the antibody remains undetectable or below the lower limit of detection, so may become negative, but RNA is cleared. But in 70% of the cases, the antibody will be persisting as well as there will be an RNA. And you might have fluctuation in ALT. So that is a chronic HCV. Now, management strategy for HCV is very, very simple. You do an antibody test. Person is positive, you confirm the infection by an RNA test. Has any amount of RNA, put the patient on treatment. So, because now you do not have those painful interferon injections, you have these all oral drugs which are known as direct acting antivirals, and we give them for a course of 12 to 24 weeks, depending upon what is your status as per the guidelines, which I have mentioned. And then after 12 week, 24 week, you give a gap and then look for the response after 12 weeks of stopping the treatment, which is known as SVR12. So you get one RNA test done at the beginning and the next RNA test for looking for a response. If the person has got a HCV viral load negative at SVR12, means the person has cleared the virus, and you give a certificate that you have cleared the HCV RNA infection. Now, there is no need for on-treatment lab monitoring. The role of genotyping and drug resistance is only limited to certain treatment combinations, only in complicated cases, not in all. And So it's a simpler virus to treat and can be done easily. But important is that those, because we know the source of HCV is through unsafe injection practices. So very commonly seen in dialysis group of patients, IV drug users. So once you give them a certificate that you have cleared, they, because of their habits, their social practices, they might acquire the infection again and get reinfected. So reinfection by HCV RNA is a very, very important problem. And as we know that there are seven genotypes of HCV, there are several subtypes also available. In India, it is the genotype 3, which is very common, followed by 1. So the antibodies, is again and again I have said, they are not at all protective. So once you are infected, it is not that you will not be able to acquire infection. Infection by 2 genotypes is also possible. Subsequent infection is a very, very important. Even if you have cleared, they get reinfected because of their social practices. So in counseling, so post-treatment counseling here is a very important factor. You have to tell them that, see, you can acquire infection from these IV drug users, so you really need to have a control of your practice. So this is the same way as hepatitis B, how the person walks in and you can enroll them into the program and give a 12-week to 24-week treatment package and can clear the virus. Hepatitis E virus infection, it causes acute jaundice. So it will always be there as clinically symptomatic jaundice case. So you'll have an abnormal ALT, very high ALT, and HEV IgM is a marker. It is an IgM type of antibody which comes into the blood and which peaks with the peak of ALT. So that is a marker by which you can actually do and confirm the infection. Although there are many tests available, but HEV IgM is an important marker by which you can confirm the etiology of acute sporadic viral hepatitis. Hepatitis A virus also causes acute sporadic viral hepatitis in children more. And again, the infection comes with clinical signs and symptoms of jaundice. So you'll have a jaundice person. The liver function test will be very high. ALT will be very high. And that is the time you just have to do a simple test, HEV IgM in the blood of the patient, and you can confirm the etiology for this infection. The treatment is not there for A and E under the program, only the diagnosis. So under this program, if you have a jaundice patient coming up to you, you'll have to do a screening for hepatitis B, C, A, and E, because these are all 4 capable of causing jaundice, acute viral hepatitis. A and E, more chances of jaundice patient to have A and E. B and C very rarely, because usually they are asymptomatic viral infection. So if a person comes to your program without jaundice, just for a checkup, so it is only B and C screening which we are going to offer. The way I have told you, B by surface antigen and C by antibody to HCV. And then if turns out to be positive, you need to put them on cascade of care. So the current status of this national hepatitis program is that, yes, it has started functioning. Unfortunately, we all know that once 2019, when the funds and all were mobilized and training started, March 2020, we all were hit by COVID pandemic, and which is still ongoing. So efforts of this national hepatitis program to roll out in several states got delayed, but still now they have again picked up. So there are 710 centers which are already there in quite a lot of states. They have started increasing the patients who are getting screened, the general population who is coming and getting screened for B and C at the these district level labs and state level labs, and a lot of emphasis on hepatitis B testing for pregnant female, and guidance on vaccination for healthcare workers at risk is being done through this program. So I summarize my talk that there are a lot of ambitious targets in front of Government of India, and through this program, we are hoping to achieve them by 2030. And this program has been launched for the same. We really need to upgrade the diagnostics and increase the uptake of testing. We want more and more general population to come up to these testing units and get themselves tested for B and C. And each state has to make a plan and put the proposal to State Health Mission so that the coordination at the National Health Mission for the program enrollment can be done. So thank you all.
Thank you so much, Dr. Ekta, for a brilliantly exhaustive and yet very systematic run through with the NVHCP. And I'm pretty sure that it was the informative presentation might have given our audiences a lot of learning regarding what goes in behind the planning of such national plans. Thank you so much. May I now invite Dr. Aisha to kindly administer the I pledge. I pledge is an oath that marks your solidarity with the cause of fighting the viral hepatitis.
Good afternoon, everyone. I welcome you all once again to today's webinar. I request you all to raise your right hand and please repeat after me the pledge. I pledge that I will try to keep my liver healthy.
I pledge that I will try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach about 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you. And back to Dr. Namrata.
Thank you so much to all the colleagues. And the forum is now open for question and answers. I thank the speakers for really wonderfully explaining all the aspects that were covered in today's session and also simultaneously answering the queries that were being posted in the Q&A. To all the audiences, if there are still open queries, I do see an exhaustive panel of the answers that have been actively directed towards the queries that are posted in the Q&A box. If there are still any open questions, kindly do feel free to post them in your Q&A box in the control panel. We do have a query that is still pending. If the girl child has been immunized at birth and received the complete dose, should we then also give vaccination to child when she becomes future mother to prevent mother-to-child transmission? I request Dr. Archana if she can take up this question to repeat the question. If the girl child has been immunized at birth and received the complete dose, should we then also give vaccination to child when she becomes future mother to prevent mother-to-child transmission? It has been asked by Dr. Ashok Kumar Srivastava.
Namrata,
Or any of our panelists.
Not there. I think I'll take it. Yes, it's universal immunization. So every child in the country is to be immunized for hepatitis B. It's under the universal immunization program. So yes, this child is to get the hepatitis B vaccine, regardless of whether her mother was given the vaccine while she was a child.
Yeah. So Manya, I think there is some confusion. I think they're asking that the girl child is at birth immunized, and when she becomes a mother, she needs to be revaccinated. But at the time of pregnancy, A and C, we do testing for hepatitis B. We are not there to vaccinate the mother. The mother gives to a birth to a child, and that child needs to be vaccinated at birth.
Thank you so much, Dr. Manya and Dr. Ekta, for addressing that query. The next one has been posted by Manikandan Srinivasan. He asks, while planning a study to assess seroconversion to HBV/HCV in healthcare workers, following a needle stick injury, what would be the ideal time for testing to capture seroconversion? Is it 6 months or 12 months following exposure?
So, can I answer?
Yes,
please, ma'am.
Yeah. So following a needle stick, so what the protocol is, there are proper post-exposure prophylaxis guidelines. We check at the time of exposure the healthcare worker, the source and the recipient. And then for a follow-up, we do only till 1 year post-exposure. But in case the healthcare worker, so you will see there is an algorithmic chart given. Now, if the exposure is to a person who is vaccinated and has an anti-HPS titer of more than 10, then nothing needs to be done. So you're neither going to follow them up or do anything. Now, if it is there to a person who's not vaccinated, never achieved, is a non-responder, then we give immunoglobulin and we complete the vaccination schedule 016 and then just do a testing for at 1 year for an exposure. Otherwise, there is no need to follow. We just have to stick to the immunoglobulin administration and vaccination for hepatitis B. For hepatitis C, yes, if the exposure, because in B, even if you're exposed and chances of B occurring, it will take a huge time for it to manifest. So we're not going to do a follow-up. Yes, for C, if an exposure from a C source is there, then you do a testing by antibody to C in a month's time, or as early as 15 days on an HCV RNA, and then you can do a follow-up testing on the person who has got needle stick injury at 6 months. That's all, not beyond that. I hope it is clear.
Thank you so much. Thank you so much, Dr. Ekta, for addressing that. In continuation of the same query, it follows with the question that is currently available rapid testing kits are as good as Eliza in detecting infections due to HBV and HCV? Just a
Dr.
little hint
Archana
of
has
doubt there.
shown, yeah, Dr. Archana has shown that the studies have come up that the sensitivity is to a tune of 90%, but the Indian available kits we have done, but the sensitivity is a tune of 70% to 80%, 20% they might miss this thing, but the specificity is always 100% with these kits. So if positive means positive, and they are very cheaply available. And the technical cumbersome of putting an Eliza and Eliza expertise cannot be given at the sub-district level. So they are easy to do, cheap and handy things, and do not require storage facility. And that is why testing by these rapid diagnostic tests is very easy to offer.
Thank you so much once again. Smriti Madhusikta has a question that Dr. Manya has previously answered as well, but it's quite a repeated query. So once again, I request you to address it, ma'am. From 0, 1, and 6 dose in adult vaccination, if someone delays the second dose of hepatitis B vaccine, say takes it on the 2nd or the 3rd month, when should be the last dose then given, Dr. Manya?
So the gap between the 2nd and the 3rd dose can be 8 weeks. So after 8 weeks, they can take the 3rd dose. If only the 3rd dose has been missed, then they can take the 3rd dose as soon as possible. So if the 2nd dose is missed, they can take the 2nd dose, and after that, 8 weeks, 3rd dose.
Thank you so much for that. Do we have any more open questions? Most of the queries have been answered in the Q&A panel. If there are any more open questions, kindly do post them. Okay, we do have time to take the one last question. Is there any age criteria for HPS AG vaccination? Is there any age criteria for HBS AG vaccination? I believe when we are giving a birth dose.
It's given in neonates as well as adults. So there is no age criteria.
Thank you for that. And I believe in case if there are further queries, please do get in touch with us, get connected with us at webinar.ilbs@gmail.com. So I'm closing the question and answer session. And I do invite Dr. Manya to kindly give the concluding remarks and a vote of thanks.
Okay, thank you so much, Namrata. It's been an excellent webinar. And although we've overshot by 12 minutes, I'm so grateful to National Academy of Medical Sciences for jointly collaborating with ILBS on this very important academic session. I am most thankful to the attendees of today's webinar. They took out the time to listen and to discuss and to ask questions. And we're so grateful for their kind attention throughout the sessions. I am so thankful to Dr. Serene for his support and for his encouragement for these activities, Dr. Kapil, who has been the driving force for these series of webinars, and of course, all the speakers. So Dr. Ajit Singh Badoriya, who so kindly lent his expertise, and Dr. Archana, Dr. Ekta ma'am, who's of course the one of the leaders for this National Viral Hepatitis Control Program. And she has and I'm also thankful to the team here in ILPS, Dr. Ankit, Dr. Ayushi, Dr. Tushar, and all the empathy team members, so Namrata, Aisha, Dr. Rahul, and Jyoti. And thank you so much, everyone, for joining in today. And we look forward to continued efforts towards elimination of hepatitis through all of these joint efforts. So thank you so much. Over to you, Namrata.
Thank you so much, ma'am, for wonderfully and very crisply summarizing it all up, and really appreciate your acknowledgement in that regard. To all the audiences, thank you so much for connecting us with today. There is a post-webinar link that has been posted in your chat box and also being displayed on your screen right now. Kindly do click onto the post-webinar link and it will lead you to a brief questionnaire. Kindly do take out the time to fill out those question and answers. Alternatively, you could just scan the QR code that is being displayed on your screen right now. We would await your pre-webinar and post-webinar answers and having them submitted to us in order to have your e-certificates delivered to you with the email ID that would be linked to the post-webinar assessment forms. Thank you so much once again for joining with us today. And to all the speakers, we really appreciate all the time that you put in to deliver your lectures, to prepare the presentations. The chat box has been flooded with compliments in how much they enjoyed the sessions and how informative it had been. So thank you all for joining us and making this webinar a successful exercise. So from ILBS and the Empathy Campaign, we'll be now signing off. Thank you so much for connecting with us. Please do get to know more about the Empathy Campaign by logging on to the www.theempathycampaign.com. If you have any suggestions, any queries, we would love to hear from you, and we'd love to pitch in the improvements in case you have any suggestions, any constructive feedbacks at webinarilbs@gmail.com.